Due to the increasing number of clients we are serving, Allied Medical Services has come up with a plan to reduce on the waiting time we spend at the clinic. For that matter, doctors will start attending to us as early as 7:40 a.m. every day apart from Thursday. You are reminded to please keep your appointment as given by the doctor to enable us plan well. Clients will be worked on according to the differentiated service delivery models they are attached to. Those on appointment will be worked on first. We are always happy and ready to serve you with love and dignity. Thank you very much.
Hello, my name is Dr. Cherop Elliott, a medical officer at Alive Medical Services. Today I'm going to talk to you about Differentiated Service Delivery Model, DSDM, which we are currently implementing at Alive Medical Services as required by the Ministry of Health. So, what do we mean by Differentiated Service Delivery Model, DSDM? DSDM is provision of HIV and TB services that are in line with the patient's needs. So I'm going to explain to you why it is important for us to give you these services of TB and HIV in line with your needs. Currently, you and me know that the hospitals or the clinics that are providing HIV and TB services have a lot in common. For example, there is overcrowding because there are too many of us that are actually going to this clinic at the same time. Secondly, there is lining up to see the clinician or to see the doctor. Now, we also know that some of us here have what we call a suppressed viral load, or a viral load that is less than 1,000 and are actually well. We don't have any problems. But yet, we have to line up and see the clinician. Now, DSDM has come to actually address some of these problems. So, how shall we make sure that each of us here are receiving the care that we need? First and foremost, as each of us here come to see the doctor or the clinician, we shall be labeled or we shall be told by the doctor that we are either stable or unstable, as I'm going to explain to you next. So when we say a client is stable, what do we mean? This person can be a child, an adolescent, a pregnant mother, a breastfeeding mother, or just an adult who has been on their current ARVs for more than 1 year. Secondly, a client who has a suppressed viral load. Thirdly, a client who has no major HIV-related illnesses. It can be pneumonia, it can be meningitis, etc. Also, TB patients who have completed 2 months of treatment and the doctor has checked their sputum again and have not found the germ of TB can be stable. And then, clients who have a good adherence. In other words, they take their medication daily and they keep their appointments, are also considered stable. Now, what do we mean by a client who is unstable? It is exactly the opposite of what I've just shared. A person who has been on their current ARVs for less than 1 year. A client who has a detectable viral load. A client who has poor adherence. In other words, they don't keep their appointments and they miss their drugs. Also, the TB clients who have not completed the first 2 months of their anti-TBs or TB medication are considered to be unstable. And finally, a client who is on third line of treatment of ARVs is also considered to be unstable. So, how shall we make sure that each of us here are receiving the services that are in line with our needs? Important to say that all the TB and the HIV services are going to be provided at the facility and at the community. And next, I'm going to explain to you how all the different approaches or different ways in which we are going to do this. The first approach is facility-based individual management, or FBIM, where a client has to come to the facility every time they need to get treatment. In this, the client will have to line up as usual to see the doctor. In seeing the doctor may see it necessary that this client needs counseling services, and so they will be sent to see the counselor. Or the doctor may see it necessary that this client needs to do some tests, so they will be sent to the laboratory. So after this client has come back from the laboratory or from the counselor, they can then be prescribed their medications and they can go home. The second approach is what we call the fast track drug refill. We shall have the client come to the facility for only one reason, that is to pick their medicines. And this approach is for only stable clients. The client will come to the triage or at the point where blood pressure, weight is taken, and after that the client is sent straight to the pharmacy, and from the pharmacy they are given the medicines and straight they go home. The third approach is facility-based groups, or FBG, and this is also for stable clients, and they can desire to form a group in the facility. The group can be between 15 and 30 people, where every time they come, they meet and share experiences at the facility. The last approach is the community client-led ART delivery, or CLAD. This is for clients who are stable and come from the same village, community, or family, and can form groups where one individual will be sent to collect and distribute medicines to the other members. We will train group leaders on how to manage groups and also how to collect medicines in turn. What are the benefits of differentiated care? Clients will not come to the facility all the time. In this, they will be saving transport, and they will use this transport in other income generating activities. There will also be reduced waiting time at the facility. Clients will be able to also manage their own care. For example, all the clients that are under fast track or are receiving medicines from the community are able to take care of themselves. There will also be better linkages of all those clients that need psychosocial support, especially those clients that are receiving medication from the community. Expert clients and peer educators will be involved more in the clinic activities. Thank you for listening. I'm Dr. Elliot Cherop, a medical officer at Alive Medical Services.